these things, they see the path to care, they see why they're having the trouble that they're having, and we start understanding three-dimensionally how to work this person. So we build this guy from bottom up, and that's what the posture listing does. Questions? So from, yes sir?
From the GP on, is that all cleaned up in X-ray?
No, no. This is done visually, either on a grid. We have a grid that people stand against, and you can see the angle, or with that self-leveling laser right here. This one right here, it draws you. It's a crosshatch, and you'll see the tilt and stuff. Now, I take pre and post X-rays in my office. Okay, there are you do not have to use this procedure. You do not have to take X-rays to use to do this procedure. But that's what I do, man, and that is part of the protocol. But I don't need to take an X-ray to work on somebody. I don't need an X-ray to validate what I do. But I'm a primary health care provider. I like looking at the degeneration. I like looking at the bending. There's a whole lot of information that you get from an X-ray, for sure. You see that certain curvatures and how they're breaking down. It doesn't help me in the correction. It just gives me more information. I like information. I think it helps me. It serves me. If I'm more balanced, three-dimensional, I could get more information. I think I take care of people better. I have, obviously, that's why I don't just go, you know, PRS-SP. This is a lot more involved. More information, three-dimensionally understanding how the body is it works for me. And that's what I do, okay? Okay, so from there, okay, we take a pre-X-ray. Here it is. I do it on everybody, okay? Pretty simple. Okay, now if you notice, I don't draw a vector anymore. Okay, I don't look at, if you're a upper cervical guy, I don't look at C over A. I don't look at the relationship to the angles. Okay, I don't look at that anymore, because what I do is I look at this to tell me this is what feeds into an algorithm to correct it. And that's what this does. So we go from a postural listing, which is the three-dimensional relationship of the leg all the way to the head, with the twisting and the turning and the weight, and then I go into an algorithm. And this is an algorithm of the headpiece, and I'm not going to get I don't want to get complicated here. It's more than just an hour and a half conversation. We take this information and we feed it into an algorithm. Remember I told you how everything has to be in reverse to the way it happened. It went off center, it compensated, and it collapsed. This algorithm takes the postural listing and sets me up on a headpiece to release that thing in an order. And what this is we set them left side up, we put the shoulder in a posterior P to A, we put the pelvis in an A to P, so we mirror image everything in our office, okay, in this procedure. And the reason we do that is because if the body's down and it's bent and it's twisted, what we do is myofascially turn the body back, no different than if you had a spring that was bent over. If you wanted to release that, you would preload it in the direction that you want to correct it in. What's that pre-direction? Orthogonal. Okay, I live in orthogonal land of the three dimensions, of not just the atlas or the head, but of everything, okay? So this thing tells me, I'm gonna start left side up, I'm gonna use a headpiece number 1, then I'm gonna flip them over and use headpiece number 3, and then I'm gonna go back to headpiece 1. And what that's gonna do is gonna release this thing from compression to stabilizer to compensator to weight. And it's going to reverse all that, and that's what that algorithm does. Okay? And I don't want to get into details. Yes, Dr.
Yeah,
Flett.
we don't need to get lost in the weeds, but basically, based on the posture data, is that there's a 3 or 4 step undoing process from the bringing on the subluxation to working the patient out of those steps, which is how the adjustment is performed. And we change patient placement on the table and change the headrest placement in order to accomplish the different goals that we have to do to work the patient back out of that 4-step breakdown and get them back as stable as we can be.
Right.
That's a whole afternoon's worth of
Go ahead.
comments.
So we take a postural listing, feed it into an algorithm, and says, okay, I'm going to start left side up, and then I'm going to do this stuff, okay? In between that, from there, which is where we're going, and what Dr. Collette just mentioned, is that we sectionally mirror image based on this posture, is that if they're posterior, we put it anterior. If it's anterior, we put it posterior. Okay? Again, if you're going to release a spring, you're going to release it towards center. So if it's already posterior, we're going to mirror image. So we've taken stuff like this, that's information from like CBP. Okay? So we're going to mirror image people based on headpiece tilt, and we do this in upper cervical anyway. If you have, like in Grostic, you've got a kink pattern, or if you have an IPSY pattern in Atlas orthogonal, or if you have a type 2 misalignment in NUCA, what you're going to do is you're going to drop the head out so that you allow the head to go, okay, and fall. The difference is that we're going to do something three-dimensionally for the whole body. Okay, that's all. All right, again, what upper cervical has done with 2 sections, we've tried to incorporate into all 4 sections three-dimensionally from the upper cervical area, okay? And we do not only release from C1, okay? Because some of those places will collapse that tension, and we don't want to collapse the tension, we want to release tension. So, that's what this is about, is there are different points, okay, that actually do different things when it comes to releasing the tension. This one up here will release things a certain way when I touch that. This one right here will release certain things when I touch that. And this one will release things when I touch that. And these things are all determined based on the head and neck relationship. So we've really taken it full circle to look at three-dimensionally where the person is standing, three-dimensionally how do we release it in that reverse at which it occurs, then where should we release it at what we call these release points so that we don't do harm, meaning if I had somebody that like this and this is a neck and I push down on it, I'm just collapsing that tension more. So looking at this thing and understanding three-dimensionally where it is, and this is really a very simple thing to do. It's just not a simple thing in an hour and a half, okay? Neither is upper cervical, okay? So again, what we're trying to do is take a 2-dimensional model to a 3-dimensional model, to reverse it, to only releasing it at places that we never do any damage or shorten the tension, and it's 3-dimensional, okay? And I just want to show you that, what tension does, okay, for just a moment, okay? So let's assume that this is a neck, okay? And I talk to my patients that tension lines are attached to muscles, and are attached to bony prominences. That's what they are. And we have like this giant telephone system, and we are the marionette people pulling those tension lines. So people say to me, well, why are you touching me up there? I know Dr. Patterson, why are you touching up here? My back hurts, I said, because I'm like a marionette person, I'm a puppeteer, and I'm able to release those tension lines from up here. I used to say it in a different way. I used to say, hey, you know what? The body's a closed kinetic chain. When I move the middle of the cup, the whole cup moves, right? So I don't look at things from an articular model anymore. I look at things from a tension model. So let's just talk about for tension just a second. So if I push on number 1, here's my tension line, here's my telephone pole. Here's a bone, here's tension. Let's call this C1 and let's call this C7. We call it the neck. So if I push here, it pulls the tension this way. Fair enough? If I push here, it pulls the tension that way. You can see that, fair enough? Very simple. When I push in the middle, I create tension going this way. So I can actually look at the relationship of the head and the neck and the whole body and pick a point that is actually going to release things and never go against what I do. When I do this, it pulls everything this way. So if I needed to move everything and release it this way, I would use this point. If I needed everything to move this way, I would do that point, and if I needed everything to come together, then I would use this point. And again, this is just, you may have no idea what I'm talking about right now, or so I'm just trying to get your concept, okay? All right, so let's talk about that for just a moment. You'll see what I mean. Okay, this is Rich. This is that guy with the 18.5 degrees. He was in my office today. He's been a patient for about 5 weeks. Okay, so this is Rich right here. We see the short side. Everybody gets adjusted on both sides. Why? Because there are attachments of tension lines that are 3-dimensional and they attach all over the place. And the only way I know to get them is to get them on both sides now, okay? So let's assume that I've got Rich right here, and on this side, he's left side up here, okay? So I took this person and I flipped them this way, all right? If you notice, this line right here. Where is it short? Where is this line short? Is it short on this side or is it short on this side? This is the right. Is it short on the right or the left? If I tilt this like this, which side is short? This is shortened to this side. This is where it's pulling, to the right. It's pulling over to the right. It's short on the right side here. No? You guys said left. This is being pulled over to the right, here like this. This is a shortened distance from here to here. This is a short distance here. No? No, you don't like that, huh? I just threw the whole wrench in the whole thing, it's all over, huh? It's all done. I'm screwed right now. I should have left for this, right? At the break? Dang, I hate that. Okay. This is short right here. Guys, if this is doing this, which way to get short? Here, it's shortened on this side. It's pulled over, okay? Muscles contract, okay? The only reason they get long is this muscle is getting pulled this way because this side is tilted this way and it's short, okay? So, if I turn this person like this, and I come into the middle of this thing, what is it gonna do? It's just gonna collapse this tension further. If I come here, what is it gonna do? It's gonna open this side up this way. And if I come on this side, it's gonna open up the whole thing like this. You see that? Which is the best place? This one, or that one? Take a guess. Which one's gonna give me the best mechanical advantage to release it? I got 15 minutes, is that what I mean? Yep. P. P's the answer, man. Of course it is, okay? All right, well, what about this side? If I do this to here, what am I going to do? I'm just going to push that down. Just think about what I'm doing. I'm pushing it down. And is that good for this person here on this one? Yes, C1 is the answer. Right, because what I'm doing is, if you take this point, push down, it'll pop that over. So when I have this person and their right side up, I hit them at C1. And if they're over here, with the left side up, I adjust them up above the ear, because that's going to release that area open. Okay? And that's just an easy little way to look at things for just a moment. I just wanted to talk to you about this and just show you that different places are going to do different things when it comes to tension. You may not see this right off the bat, but it is a very simple thing if you just look at a rubber band, the way that you move tension around in a clothesline. All right? So here's Rich, okay? Here's Rich. First, one correction. Dr. Pat says it's pretty darn good, isn't it? Come on, man. Give it up for Friedman. Come on. Come on. I'm telling you, this is a good correction, man. You don't, this is, look at that thing, man. Jeez, man, I thought I needed dynamite to move that thing. I said, don't make me, I tell patients when I see that, don't make me use my knee. Right? Okay, so I want to tell you about this guy. I'll tell you about him now. Okay? He just did a YouTube for me. It'll be up probably in the next week or two. All right? You'll see it. All right? Because I'm doing 2 YouTubes every month with me talking and then one with a testimonial. All right? To get the word out. So this guy comes in. He has Parkinson's and dementia. Okay? He is in a wheelchair. He can't walk. He can stand up. And he stands up and he's all bent over. You know, he's in that contraction. I get him on the PMD, he's 40, 50 pounds off, he's walking like this. The guy is literally able to say a word to me. Yes, no, staring off like this. I'm telling you, it's 5 weeks of care. The guy is walking with a walker. He walked out with his walker, holding his walker at the beginning of the week. I see this guy twice a week for the past 5 weeks. Somebody asked me about the care that I do. I generally do twice a week for a week or two and then once a week. You know, and that's it, okay, for about 4 months. 4 or 5 months, that's my care plan, okay? Why? Could it be more? Sure, it could be more. More is better, right? The more you move it, the better it is, right? But the thing is, you know, I try to treat people the way that I like to go do things too. So that's the way I run my office. I see people once a week. Nice and simple, tomorrow's another day. I'd rather it take time, give the body a way to express itself. It may not be good for you, it doesn't matter. Somebody asked that question. But what happened was, is after I adjusted him, he slowly started to wake up. The guy has full conversations with me. He's present 100% of the time. Now, please, somebody tell me how Parkinson's and his neck and his misalignment with 40 pounds is related. I have no clue. All I know